So welcome everyone to today's session. I'm Sally Leech from Henpicked Menopause in the Workplace, and delighted to be joined today on this subject around endometriosis by Dr. Abbie Laing. So Dr. Abbie is a GP and a menopause specialist working with both the NHS and My Menopause Centre. So welcome, Dr. Abbie.
Thank you.
And so we're going to get straight into the topic, because I think this is something that we all have often heard the word, but actually really understanding more about, first of all, what is endometriosis?
Yes, what is endometriosis? So to explain what endometriosis is, it's probably important if I explain what the endometrium is first. The endometrium is the lining of the womb. And every month that grows in response to estrogen. And if pregnancy doesn't happen, it's shed as a period. And that is the endometrium. Endometriosis means that there is endometrium-like tissue outside of the womb. So it's tissue that's very much like endometrium, but it's in the wrong place. So usually it should always be in the womb, but endometriosis is found when endometrium-like tissue is outside of the womb, and that, for example, could be on the ovaries or on ligaments around the womb, outside of the womb, on the surface of it, on the bowel, on the diaphragm, on the rectum, or on the bladder. And what happens is that this endometrium-like tissue behaves, the endometriosis-like tissue behaves like endometrium. So every month it grows in response to estrogen, and then if pregnancy doesn't happen, it sheds, and that can cause pain in the area where it's growing. And when it's shed, there's nowhere for it to go, so the body has to reabsorb it, and that can cause pain and symptoms around where it's located.
Okay. And in terms of why that happens, so is there a particular reason? What causes it? And are there some people that are particularly prone to this? Does it happen at a particular age?
It's $1 million question. So we don't know why it happens. There's lots of different theories. Certainly, we know that some people are more prone to it, and it does appear to run in families. So there does appear to be a genetic predisposition. There are other theories. One theory is that the endometrium or blood flow goes the wrong way. And this is called retrograde menstruation. And that means that endometrium-like tissue flows backwards through the fallopian tubes and into the abdominal cavity, and then it seeds there. That's one theory. Another theory is something called metaplasia, which means that the cells have changed. So cells, for example, on the bladder, which are bladder cells, change to become endometrium. But it's not fully understood what causes it.
Okay. And is there anyone that's particularly more prone to experiencing or suffering from endometriosis? Does it generally happen at a particular age?
It's more likely to happen in women who are in their reproductive years, because that's when our hormones are fluctuating, and that's when endometriosis can grow. So in response to estrogen going up, it can grow. So in general, in women aged 25 to 40 is when it's most commonly diagnosed. But in anybody in their reproductive years, they could have endometriosis-like symptoms. It's less common post-menopause, when our hormones settle and estrogen levels are low. And certainly there does appear to be a genetic basis, and where it's running in families, somebody may be at a higher risk if they have a family history of it.
Okay. A couple of people are just saying, Abbie, if you could just talk a little bit louder.
Yes, sorry. I'll talk a bit louder, sorry.
Thank you very much. And in terms of, I know you said about pain and that people may be experiencing, what kind of symptoms in general might people experience when it comes to endometriosis?
Symptoms of endometriosis differ between individuals depending on where the endometriosis is located. So, for example, if it's located on the rectum, then somebody might have bowel symptoms. If it's located on the bladder, then somebody might have urinary symptoms. But the hallmark usually is that pain is worse in the lead up or first few days of someone's period each month. And that is when hormone levels are declining, and you would expect a bleed to happen, but there's nowhere for the bleed to be shed if it's not in the womb. So usually it's cyclical symptoms that are worse before or the first few days of a period, and the type of symptoms that happen will depend on where the endometriosis is sitting in that person. But they vary between people, and it's very hard to diagnose because they are so variable. And it takes about 7.5 years on average to diagnose endometriosis in a person. It commonly gets diagnosed as IBS if it's sat on the bowel and can be mistaken for IBS-like symptoms. But the hallmark is that it's cyclical. The hallmark is that it's worse in the lead up to the period and first few days of the period for a person.
And in terms of then following from that, how this is diagnosed, because as you say, that the length of time it takes on average to diagnose, it was a really shocking number when I first learned that. And what's the reason behind that, and how is it in general diagnosed?
In my opinion, the reason it takes so long to diagnose is because there's not a very good screening tool for it. So it's very hard to see endometriosis on ultrasound scans. Sometimes you can see it, but it's very difficult. And an ultrasound scan is not a good screening tool for endometriosis. So therefore, people can have scans, which picks up a lot of gynecological conditions, but commonly misses endometriosis. And because endometriosis can present differently depending on where it is in the tummy, it presents with different symptoms in different people. So it's quite a hard or a vague presentation in a lot of people. In terms of diagnosing it, the gold standard diagnosis is a laparoscopy, which means putting a camera through the belly button and having a look, and you can see it visually at laparoscopy. And that is the best way to diagnose endometriosis. So if somebody is concerned that they have endometriosis, they should be referred to an endometriosis specialist, which usually falls under gynecology, and that person will take a very detailed history and decide whether or not they want to go on and do a laparoscopy. Sometimes people have MRI scans, which is a better tool for diagnosing endometriosis compared to ultrasound scan, but still the gold standard test is laparoscopy. And I think that it's hard to diagnose endometriosis because routine scans don't pick it up.
Okay. And in terms of if somebody thinks that this is what they're experiencing, or wants to be, what advice would you give to somebody if they're concerned about the symptoms they're experiencing, in terms of talking to their GP, and how do they take that forwards to understand more what's going on for them?
So my first piece of advice would be to create a diary of your symptoms, because often endometriosis will jump out at you as being cyclical when you make a diary. So if you note when your bleed happens each month, if you have a bleed, then you can commonly see that symptoms are specific in the lead up to the bleed or the first few days. And that's really powerful then to take to your clinician and say, look, my symptoms are cyclical. There is a link here. Write your symptoms down. And then if you think that you have endometriosis, you should be going to your GP or your clinician, and you should be asking for a referral to an endometriosis specialist, because it is a subspeciality in gynecology, and there are some subspecialist gynecologists who practice in it regularly.
Fantastic. And in terms of the risks around having endometriosis, are there any particular risks or considerations people need to be aware of?
So depending on where the endometriosis is, so for example, if the endometriosis is located on the ovaries, then this can put somebody at risk of ovarian cysts, which are called endometriomas. And endometriomas can twist, or they can cause pain, and they can bleed. And that can cause pain in a person, and it can sometimes even damage the underlying ovary, which can reduce fertility in some people. And we know that there are higher rates of subfertility in people with endometriosis compared to people who don't have endometriosis. Similarly, where endometriosis can become, where it's shedding but can't be released from the body, it can cause adhesions, which means that organs can start to stick together, and that can cause pain for people, and people can struggle with chronic pain and debilitating symptoms. And if endometriosis is stuck on the bowel, somebody might struggle with bowel symptoms. If endometriosis is stuck on the bladder, they can struggle with urinary symptoms, and all of these can cause our own set of unique symptoms in a person, or problems in a person. to treat endometriosis, usually or sometimes surgical treatments are given, which is undertaken by a gynaecologist who will usually try and do it laparoscopically through a keyhole, and they will use diathermy to remove endometriosis. And of course, that comes with the risks of having surgery, which can include things like adhesions postoperatively or infections, and other risks with surgery. So those are the sort of main risks, and usually risks relate to where the endometriosis is and how severe the endometriosis is for that person.
Okay. And obviously this is part of our monthly cycle, that you're saying that this is where people are starting to see a great way of understanding whether this could be relating to endometriosis is that cyclical nature. How does this affect when people start to reach perimenopause and go into and through and past menopause?
So we are very used to our cycle all the way up until the perimenopause. So we have a cycle where estrogen tends to go up, peak mid-cycle ovulation, and then go down. And in the perimenopause, we start to lose this lovely pattern of estrogen, and it becomes erratic like this. So in the perimenopause, we can have erratic estrogen and erratic periods. And when periods get heavier or closer together, that can actually make endometriosis symptoms worse. But then as you transition throughout the perimenopause, closer towards the menopause, hormone levels tend to go down and stay down and become low. And actually, the symptoms of endometriosis usually lessens. And for a lot of people in the menopause, they disappear. So the menopause is a time when endometriosis is more quiescent for a person in general.
Okay. That's brilliant, thank you. And just on that note, someone's asked around the risk of taking HRT in a person with endometriosis.
A brilliant question. So HRT is not contraindicated in somebody who has endometriosis, but it's important to pick it carefully. And if we think about the traditional two hormones in HRT are either estrogen and progesterone. And estrogen is needed for symptoms, and progesterone is needed to keep the lining of the womb, the endometrium, thin. So estrogen is the hormone that can stimulate endometriosis because it stimulates the lining of the womb to grow. And progesterone is the hormone that suppresses it, and it keeps the lining of the womb thin. So with HRT, the principles really should be, where possible, giving a low dose of estrogen, because that reduces any stimulation as much as possible, and a continuous progesterone, because that provides constant suppression of the endometriosis growing. So you want to use the lowest dose of estrogen you need with a daily progesterone to prevent an endometriosis flare. And if your endometriosis is confined to the womb or very close to the womb, then the Mirena coil is a good option for preventing endometriosis from flaring. But if it's wider than the womb or further outside, for example, towards the diaphragm or on the bowel, then you might need a progesterone taken in addition or separately to the Mirena that gives you better coverage elsewhere.
Okay. And just on that, someone said that they have endometriosis and they were advised after a hysterectomy that they needed progesterone as a preventative.
That's a good
and and then they've been told by somebody else that maybe it's not necessary to keep going with that. Just kind of what's the advice around post-hysterectomy?
Really good question. So when somebody has had a hysterectomy, when someone's had a hysterectomy or a total hysterectomy, then usually traditionally that person can use estrogen only HRT because they've had their endometrium removed. However, if somebody has endometriosis, then that might be left behind post-surgery. And if that's left behind post-surgery, then that person should have progesterone daily to prevent it growing in response to estrogen. So that person would still need to have a combined HRT. Now, if the surgeon was certain that they removed all of the endometriosis and there was nothing visible left, sometimes after a year, estrogen-only regimes are used. But if there is any symptoms suggestive of endometriosis that come back, a progesterone should be added back in. But I would only go to an estrogen-only regime if somebody is certain that their endometriosis was removed post-hysterectomy.
Okay, that really helps to make sense. And I've got a question here around kind of managing the symptoms, especially while you're waiting for treatments. So someone here is an example, they're waiting for a gynecologist referral, recently been prescribed strong painkillers which have a risk of addiction. Any advice on managing symptoms, in particular the pain that we know, and there's so much sharing, and thank you everyone for sharing so many of people's experiences, which we know are really, really challenging for people, of how people actually manage that pain, or how poorly this can make them feel.
Yeah, and it can be really debilitating, endometriosis. People really, really struggle with it. In terms of treatment options, treatments that switch off ovulation or treatments that lower estrogen levels in general, so these are hormone manipulations, can help people. So, for example, using the progesterone-only pill can help, or using the progesterone injection, or taking the mini pill, or using the combined contraceptive pill. For a lot of people, that will significantly reduce symptoms caused by endometriosis. For some people who have endometriosis, using the Mirena coil, if the endometriosis is confined to the womb or close to the womb, it's a very, very powerful tool for reducing endometriosis like pain. More sort of severe or higher up the scale of things that can help include something called GnRH analogues, which are sometimes prescribed by gynecologists prior to surgery. And GnRH analogues, they tend to switch off the ovaries completely, so they cause an induced menopause, and so they usually are given back with add-back HRT. But I've had a lot of patients, and though they feel scary, I've had a lot of patients who feel that their quality of life has come back when they've been put into a chemical menopause and had add-back HRT, because it treats the endometriosis symptoms. So that's something that can sometimes be tried for people prior to waiting for surgery going forward. And then those are your hormone treatments, but you also have your analgesics, so things that can help with pain. And then there's two really that we go to. So we've got mefenamic acid, which can reduce prostaglandins at the time of menstruation, and that can be really helpful for pain. There's also tranexamic acid, which reduces the amount a person bleeds, and that also can help with pain for a person with endometriosis. So mefenamic acid, tranexamic acid, certain hormone treatments, and then for those people waiting for surgery, a trial of a GnRH analog with add-back HRT would be a very good approach for a person.
And would that kind of treatment be done through a gynecologist or an endometriosis specialist?
Yes, that's right. So it's normally recommended by a gynecologist, initiated by a gynecologist, as a way of seeing, will this person benefit from having surgery really, or helping this person going forward.
And I think that's the frustration, I think, for many, just looking at some of the chat around the time it takes to be able to see somebody and managing those symptoms while. And I think this is that length of diagnosis again.
Absolutely. And so in primary care, things that can help people are things like those hormone treatments, so combined contraceptive pill in women who are eligible, progesterone only pill. And then you've got your simple analgesics, mefenamic acid, tranexamic acid. But often women do need to see an endometriosis specialist to get full symptom control, and they should see one.
Okay. And we've got a few that have asked around, can endometriosis come back after it's been removed? Can you have surgery more than once around endometriosis?
Yes. So we don't fully understand endometriosis coming back, but certainly there have been cases where it's been reported that the endometriosis has been removed and then it has come back again. So it's not something we understand well, but there have been cases where this has happened. In terms of surgery, yes, you can have surgery more than once. The more times you have surgery, there is always the higher risk of adhesions or post-operative complications, but many women do have surgery more than once and need to have surgery more than once. And sometimes surgeons start with minor surgery, laparoscopies, but eventually women do need to end up having things like hysterectomies for their endometriosis. So there are patients who have recurrent laparoscopies, and if they need to have that, then absolutely they need to have that.
Okay. And someone's obviously we've talked about the symptoms can differ depending where this is in the body, and I think the fact that endometriosis is often diagnoses things like IBS, and people have asked a little bit more understanding around the symptoms around bowel and bladder endometriosis, and how can someone understand the difference, and also challenge about if they're being diagnosed with IBS but they don't feel it's IBS, what would you suggest they do in that situation?
And this is a brilliant question. So if endometriosis is sat on the bowel or outside of the bowel, then it won't be visible if somebody has a colonoscopy. It won't be easily visible. It's hard to see on scan. So it can go missed. And if something's sat on the bowel, then it might cause rectal pain. It might cause diarrhea. It might cause constipation. It can cause all sorts of different bowel symptoms. It might even cause blood in the stool. But the hallmark of endometriosis usually is that it's cyclical for a person. So if somebody's getting cyclical bowel symptoms and it's worse in the week before their period or the first few days, it might suggest endometriosis, and it might suggest endometriosis around the rectum. Similarly, if endometriosis is on the bladder, then it might cause blood in the urine, or it might cause urinary frequency, or having to get up at night or not be able to hold the bladder for as long. Or some people get a pressure-like feeling on their bladder, feeling like there's something on it pushing down. And again, that will usually be cyclical. So it's usually worse in the week before the period in the first few days. So if you have symptoms outside the traditional gynecological symptoms, then it's worth keeping a diary to see if they're cyclical, because that strongly points towards endometriosis if it is. And some people get all of them. Some people with very extensive endometriosis will have bowel, bladder, as well as heavy periods, painful periods, pain on intercourse, and other symptoms with it. But if you think that yours is slightly more nuanced, then keeping a diary of cyclicity, so whether it's linked with periods, can be very helpful for a person.
Excellent, thank you. And someone's asked, how do GPs differentiate between endometriosis and adenomyosis?
Yes, so they're slightly different things. So endometriosis is endometrium-like tissue in the wrong place outside of the womb. So that could be, as mentioned, on your diaphragm, on your rectum, on your bladder, on your ovaries, on your ligaments. Adenomyosis is endometrium that's grown into the womb. So it's not outside of the womb, it's grown into the womb. And that thickens the womb. So it makes the womb much more bulky, and that can predispose to heavier, painful periods each month. And adenomyosis is easier to diagnose by ultrasound scan. So usually when you look at the womb on scan, you can see that the muscle layer is thickened and it points towards adenomyosis. Whereas endometriosis, because it's outside of the womb and it's sort of floated somewhere else or begun somewhere else, is much harder to see on scan. Hopefully that answers that.
And are there difference in symptoms that people might experience?
So they're both cyclical, but traditionally adenomyosis is, because it's in the womb, so it's womb-related symptoms. So traditionally, it's very painful and very heavy bleeding, whereas your endometriosis, the symptoms will depend on where that endometriosis is. So if your endometriosis is outside of the womb but stuck on it, it might be that you get womb cramps each month. But if it's on your rectum, it might be actually that you're getting diarrhea or something like that each month. So slightly different symptom profiles depending on where the endometrium is for that person.
Excellent, thank you. And someone's just, and I know you touched on this, asked around the effects of endometriosis on fertility.
Yes.
And just if we could go through that a little bit more detail.
Course. Yes. So there is not causation, so we can't say definitively that if somebody has endometriosis, it is associated with infertility. But there are higher numbers of women who struggle to conceive who have endometriosis than don't have endometriosis. And it's not well understood why this might be. But the theory is that if somebody has endometriosis around the ovaries, then that can actually sometimes damage the ovary, and that can reduce the number of eggs, for example, or the egg quality in the ovary. Or if somebody has endometriosis around the tubes that the egg will flow along, then that can make the tube more scarred or the tube more sticky, and that might make it more difficult for the egg to flow along. Or if somebody has endometriosis or adenomyosis in the womb, then that can make implantation harder for fertility. So the theory is that there might be scarring, or the womb or the fallopian tube or the ovaries might be damaged by endometriosis being there. But not everybody with endometriosis struggles with fertility. We just find that there are more people in fertility clinics with backgrounds of endometriosis.
Yeah, and we've had a lot of people sharing around the Mirena coil's been an absolute godsend for people. Just can you just talk us through a little bit more
Yeah,
around
of
how
course. Yeah.
that makes a difference?
So if we go back to how endometriosis grows, so we want to avoid anything that makes endometriosis grow, because that will cause pain. And so estrogen can make endometriosis grow, but progesterone does the opposite. Progesterone suppresses endometriosis and keeps it small. And so the Mirena coil is a progesterone, and it's a progesterone that sits in the womb, and it releases continuous progesterone every single day in the womb. And that's quite a high dose that it releases in the womb, and it's quite focused to those womb structures. So if somebody has got endometriosis that's close to the womb, so around the ovaries, around the fallopian tubes, then that is a constant progesterone on that endometriosis, which is going to be suppressing it. And it works really, really well for a lot of people. A lot of people are absolutely amazed by the effect of that coil. We think, and we think it works for what we call extrauterine. So, if you've got endometriosis what wider on your bowel, people do seem to find that their symptoms are improved with the Mirena still, but it's not been well studied, and we can't say with certainty that progesterone is adequately going to prevent extrauterine endometriosis. But certainly anecdotally from clinic, people seem to do really well with a Mirena coil, and it's because of this daily, it's a continuous progesterone. So unlike if you're taking a tablet, which might raise the level, and it takes a while to get to the uterus because it has to go through the bowel and into the bloodstream, this is continuous progesterone all the time being released into the womb, which suppresses growth of then the endometrium and endometriosis subsequently.
That really helps. And I think people are then just wondering around, obviously, if the combined pill or progesterone only pill or the Mirena coil are ways of helping to manage this, but people are then looking to try for a family.
Yes.
It's that balance of, is taking those things going to have an effect on that, or any considerations around that?
Yes, so if you're somebody who's trying to conceive, then the Mirena coil is considered a contraception, as is the mini pill and the combined contraceptive pills. And that puts these people in really tricky spots, actually, because they are also contraception. So the Mirena is a very effective contraception. It also prevents heavy menstrual bleeding. So if somebody wanted a family, then they wouldn't be able to use the Mirena coil because it would prevent pregnancy. And that's the same with the other hormone methods. So that person would be looking at using painkillers, using things that can reduce flow, such as tranexamic acid each month, mefenamic acid. And that's much harder for these ladies. And ultimately, there is a case that perhaps they should be seen more quickly by gynecologists because they can't use traditional methods because they want to conceive.
Yeah. And is there, anything that people can do to support themselves? Because obviously, I've said, just everyone, again, thank you so much on these sessions. Everyone shares so openly, and it's so appreciated that people aren't feeling like they're going through this on their own. But it's really hard from the experiences we're hearing here. I guess kind of giving people a bit of hope or a bit of a...
Endometriosis is actually not uncommon, and you can feel really alone with it, but it affects 1 in 10 women. So that means that for every 10 women you see, 1 in those women will have endometriosis. And so, in my opinion, the most helpful way is to talk about it, like we're talking about it now, raise awareness, people open the conversation, improve awareness, because the likelihood is somebody in the room that you're in also has endometriosis or is struggling with symptoms of endometriosis. So although you feel alone, you are not alone. And it's a very hard condition to diagnose. So don't doubt yourself. If you think that you have it and you have these cyclical symptoms, you should seek a review with an endometriosis specialist. And absolutely everybody deserves that opinion.
Fantastic. Thank you so much. And I think really sums up why these sessions are so important, because we do want everyone to feel that they're not on their own when they go through these things. And we think around the way we've we open up and talk around many of the topics we talk about when it comes to menopause, not knowing that you're not on your own, knowing what you're feeling is normal. And I think what you said there, Dr. Abbie, about not doubting yourself, we always say that you know your own body the best. And when things don't feel right, it's okay to push and say they don't feel right, and asking for that help and support.
And there will be online support groups. There will be endometriosis online support groups where you can meet other people who are going through similar journeys, and you can share your experiences, and you can share things that perhaps have helped you that with other people, and vice versa. Because remember, 1 in 10 people have it. So there are a lot of people struggling with it. You're definitely not alone.
Absolutely. So thank you very much, Dr. Abbie. Really appreciate your time. Really appreciate everyone sharing. And we've gone through as many questions as we can do. There were a few questions around PMDD. That's another topic we're going to be covering soon, and also around fibroids and cysts. And again, these are topics we're going to be covering soon in upcoming Lunch and Learn. So please keep a lookout on the Menopause Hub, and we'll be sharing any new Lunch and Learns, and the recording of this session will be shared there. But thank you very much, Dr. Abbie, for joining us, and thank you everyone for sharing so openly, and we look forward to seeing you on the next session. Thank you.